My name is Viviane Lima. I work for the British Columbia Center for Excellence in HIV/AIDS. The title of my presentation is Evolving Patterns of Brand and Generic Antiretroviral Drug Utilization Within a Universal Healthcare System in Canada. I have no disclosure to declare. Since the availability of zidovudine as the first antiretroviral drug to treat HIV in 1987, health outcomes of patients living with HIV have improved dramatically. Although the efficacy and effectiveness of these drugs are unquestionable, advances in therapeutics come at a high price, and the increasing cost of new drugs are putting considerable pressure on different healthcare systems. To cope with the high cost of drugs, generic drugs play a central role in the sustainability of healthcare systems. So, in this study, we modeled the utilization of both generic and brand ARV products in a public-funded HIV treatment program to improve the understanding of the market share of prescribed ARVs and generic drug penetration. The data was based on the BC Center for Excellence in HIV/AIDS drug treatment program, and the data included drug utilization between the fiscal years 2014-15 and 2019-20. We modeled each ARV separately, including naive and experienced patients. ARVs with low utilization were combined and analyzed together. 100% adherence to prescribed dosing for the quantity dispensed for each drug was assumed. Dispensations of a single dose or greater were considered. The explanatory variable was timed, defined by each fiscal period between 2014-15 and 2019-20. Please note that each fiscal year has 13 fiscal periods. The outcome was the proportion of patients who received each drug per fiscal period. The denominator for this proportion was the unique number of patients enrolled in the DTP who had a prescription dispensed during this time. Patients can switch drugs within the fiscal period, and therefore the sum of the proportion of all drugs modeled within that particular fiscal period can exceed 1. The count of patients was modeled assuming a negative binomial distribution. The proportion of patients receiving each drug was modeled via beta distribution, and if the trend was nonlinear, it was modeled using a generalized additive model, and we used cubic regression splines to smooth the trend over time. And if the trend was linear, we modeled it using a beta regression model. The ARVs that were modeled between 2014-15 and 2019-20 are listed in this slide. We had several brand antiretrovirals, 7 generic antiretrovirals, and for those antiretrovirals with low utilization, we combined them and modeled them together. Some of the results. Here is the generic breakdown over time. So our first generics were introduced in 2017-18, and you can see the most individuals were on Abacavir 3TC. Over time, the distribution changed a little bit, and in the last fiscal year, we saw that there was a significant proportion of people on FTC TDF. People were also receiving Abacavir 3TC, and others were receiving Atazanavir. Next, we show our model results. In this case, we used this model because we wanted to provide confidence intervals around our estimates, and also we would like to one day be able to forecast the trend of these drugs. So the first plot, we show the number of patients over time, and you see that the number of patients increased dramatically during the fiscal years that we looked at, and it seems at the end it's plateauing a little bit. Next, we show the proportion of patients or the percentage of patients on each one of the drugs that we modeled on the y-axis, and the x-axis is the period of time. As you can see in this slide, most antiretrovirals, the Utilization is decreasing over time. And for dolutegravir, abacavir, and 3TC, it's increasing until the latest fiscal periods, and it seems that it's declining. But at the same time, you can see in the bottom here, there is the utilization of bictegravir with FTC and TAF. And it has sharply increased in our drug treatment program in the last fiscal periods, but it is a little bit early to tell what will happen with bictegravir in our program, but we are updating this data to model the trends since 2019-20. The next slide, we show several other drugs that we modeled over time. And moving into the last slide, for these modeling results, we see that there are some interesting patterns here. For example, if you look at the percent of people on nevirapine 200 milligrams, you see a sharp increase of this drug in the latest periods. It's because nevirapine 400XR has been discontinued, and there was a significant proportion of patients who moved into nevirapine 200 milligrams. And you can also see the distribution of the low utilization ARVs that has decreased at the same time, and that was because of the nevirapine 400XR. Next, we show the ARV breakdown. Here we look at all the ARVs that we modeled and in the last fiscal year. So as you can see, there are both backbones and brand products. We have generic products as well. And I included ritonavir because this drug was dispensed. So in terms of third drug, you can see that dolutegravir is the third drug with the most usage, especially if it was used in combination with abacavir and 3TC. As I mentioned before, there are some generic formulations of FTC-TDF that is also significant, but that is a backbone. And in terms of the other third drugs in combination, you can see that they are reasonably distributed in our drug treatment program, and there is a little bit of bictegravir in this pie. Next, we show the impact of new ARVs. And on the y-axis, we show the percent change from previous period, and the x-axis are the periods of time. And in red is dolutegravir by itself. In green is dolutegravir combined with abacavir 3TC. In dark blue is the combination of bictegravir, FTC, and TAF. In light blue is the low utilization ARVs, and in orange the other ARVs. You can see basically 4 peaks in this graph. The first one, and if you look at down in the plot below, you can see a closer look of what is happening. So the first one was the introduction of dolutegravir, which displays some of the low utilization and other ARVs. And then the second peak was when the combination of dolutegravir, abacavir, and 3TC came into the market, and the DTP included in the formulary. So several people who were on dolutegravir alone, plus some backbone, moved into the one pill. And there was some movement from the other drugs as well. And then there was the first peak for bictegravir, which was when bictegravir was approved to be used in Canada. So there were some studies that the patients were enrolled and they received bictegravir. And then there was a second peak of bictegravir. That was the non-CFE supply that came into the CFE. And the last peak was when there was a change in guidelines and the formulary where bictegravir was formally in the formulary. And you can see it displaced a lot of the low utilization ARVs. So in summary, there has been a significant shift in ARV usage in BC, consistent with evolving guidelines, We have seen a market shift towards the use of integrase inhibitors, which now dominates the market share in BC. And we have also seen a recent decline in penetration of generics, imposing a significant economic impact. Thank you.